All right, we're now talking about the arm and the forearm muscles that move the elbow joint or the forearm, more specifically forearm for rotational type motions or motions that occur across the wrist into the hand originate in the forearm. But as far as elbow bending or extending, flexing or extending, that's really more muscles of the humerus that are doing majority of the actions there. That said, the limbs are organized in compartments that are surrounded by deep fascia. The compartment housing functionality related muscles to the anterior compartment has primarily flexor muscles. The posterior compartment is really the extensor muscles, typically speaking, for the shoulder. I'm sorry, for the elbow, excuse me. It says the arm, but it's really the elbow. The anterior compartment supplied blood by a deep brachial artery. It's innervated by the musculocutaneous nerve. It includes the biceps brachii and the brachialis. And the posterior compartment of the arm has the extensor muscles, so the elbow extensors. It's supplied blood by the deep brachial artery, and it's innervated by the radial nerve, and it includes the triceps brachii. For the biceps brachii, it's a two-headed muscle on the anterior portion of the humerus, although the biceps brachii also goes and attaches to the scapula. That should be mentioned as well. That's why the biceps brachii plays a role with shoulder flexion to some extent as well. It's a synergistic flexor of the shoulder, not the primary motion there, but they're a synergistic flexor, and we'll see that in a second when we see the actual attachment points or the origin for the biceps brachii. One of the origin points. It also flexes the elbow and supinates the forearm because of its attachment on the radius and the fact that it goes between the radius and the ulna, wraps around and then pulls it around into supination. It's the primary involvement. Its primary involvement is when you're in supinated position of your forearm while performing elbow flexion, whereas, and it's often why it's often referred to as the brachialis being the most powerful elbow flexor. It's not so much the most powerful, it's that it's the only one that attaches the ulna, so consequently it really doesn't matter what position your forearm is in when you perform elbow flexion, your brachialis is still playing some role in terms of whether you're in supinated forearm position, neutral forearm position, or pronated forearm position. It's still elbow flexion by the brachialis is still playing a role. But it's not playing as big a role as a biceps brachii is when it's supinated. When your forearm is supinated. Brachioradialis, and this is incorrect, I put this on here, dominant and pronated flexion. It's actually not dominant and pronated flexion. That's the brachialis that's dominant and pronated flexion. It's around when you're anatomical neutral, it's still playing a role, never really is the primary mover relative to the other bicep muscles at any point. However, it does play some role both when you're in supinated position or in neutral position. But as soon as you go into pronated position, it's mostly brachialis doing the elbow flexion. And so here, taking a closer look here, looking at our biceps here, the biceps brachii here, and the biceps brachii short head here. And this would be the triceps behind there, brachialis underneath the biceps brachii, and here's a brachioradialis crossing more from the forearm, more toward middle forearm and coming across here from the radius. Both the biceps brachii and the brachioradialis attach to the radius, and the brachialis attaches to the ulna once again. Here's our bicipital aponeurosis here. And so here we can see in the posterior view, the biceps brachii, both long and short heads, both attach to the coracoid process of the scapula, which is why they're involved in shoulder flexion, whereas the essentially the brachialis here only attaches to the humerus, does not reach that far up. It's playing a role only in elbow flexion specifically. It's also a lot smaller muscle than the biceps brachii, so why it would be referred to as the most powerful elbow flexor is kind of uncertain to me, but it's actually not accurate. It's actually it's the only one that plays a role in every position of the forearm with elbow flexion because it attaches the ulna, and the ulna rotates like any other bone would do, typically speaking, at a given joint to some extent. But the radius rotates over the top of the ulna and comes back, which is why it's so much more of an effect upon the biceps brachii and the brachioradialis by what the forearm position is. Triceps brachii, now they attach to the ulna, also as well as the humerus, and the long head also attaches to the scapula, which is why the long head is playing a role with shoulder extension from a synergistic standpoint. But its primary job of the triceps is simply elbow extension. It really doesn't matter what position your forearm is in, whether you're in supinated forearm position, neutral, or in flexion, because the triceps attach to the ulna, and the ulna is not affected by the pronation or supination of the forearm, whereas the radius is. And conius is a synergistic elbow extensor, excuse me. The textbook refers to it as a weak elbow extensor. That's simply because it plays such a small muscle, playing a much more minor role with elbow extension, whereas it's mostly triceps playing the major role there. It crosses the posterior lateral region of the elbow. And so here we have First of all, like there's our rotator cuff muscles, which we'll come back to later on, supraspinatus, infraspinatus, and teres minor, although your subscapularis is not shown in this picture here. But our triceps, our lateral head here, and our long head here, and the medial head there, and there's the anconeus. But you can see now here's where the long head attaches actually to the inferior border of the scapula here, whereas the lateral head does not touch the scapula, it only goes to the humerus. That's why the only one that's playing a role with the extension of the shoulder is the long head only. And the medial head is here, also only attaching here at the humerus, not originating on the scapula. And that's where the origination is, right? And that said, and of course, here's the triceps brachii, the medial head underneath. You can see a bit of a better look at it than from the long head here over the top, and the lateral head being over the top of it. As far as the muscles of the forearm that act on the elbow joint, pronator teres and pronator quadratus rotate the radius across the ulna to help pronate the forearm, going over the top, help with pronation. That said, they are located in the anterior compartment of the forearm. Supinator supinates the forearm, opening up. And it's located in the posterior compartment of the forearm. So here we have the muscles basically showing here is our supinator, our pronator teres, and across here from the medial epicondyle and wrapping around there with that radius there. And then we have the supinator here playing a role as well at that radius there. And the interosseous membrane, again, of course, remember that membrane between both the radius and the ulna, as well as the fibula and the tibia. And here's a pronator quadratus. Now, tennis elbow or lateral epicondylitis is typically due to trauma or overuse of the common extensor tendon, the posterior forearm muscles. There's pain at the lateral epicondyle of the humerus, more to the outside. If you're in a supinated forearm position, it's on the more toward the basically toward the outside, right? It's at the lateral epicondyle of the humerus typically in the tendon's attachment site, and often is resulting from repeated forceful contraction of forearm extensors. But really, when we say forearm extensors, it's really elbow extensors, triceps. And oftentimes simply relieving, not doing so much stress going into extension. And one of the reasons why people with tennis elbow, there's that locked elbow type position going into like a forearm, or a forehand stroke, and of course going into backhand stroke, it's still going to go into extension. It's a lot of extension. Serving, it goes into extension. It's a lot of stress in extension while gripping that creates an issue for tennis elbow. It's really the combination of the grip with the extension, both. Trying to release the grip and not just having a tight grip, and also doing more elbow flexion exercises to relieve stress on the elbow extensors can play a role with relieving tennis elbow issues as well. Forearm muscles that are extrinsic to the wrist and hand that are partitioned to the anterior and the posterior compartments. We have our anterior compartment muscles that generally flex the wrist. Some flex the interphalangeal joint, the IP joint. They mostly arise from the medial epicondyle of the humerus. The posterior compartment muscles that generally extend the wrist. Some extend the metacarpal phalangeals, the MP, and interphalangeal joints, IP joints, but most arise in the lateral epicondyle of the humerus. The retinacula of the forearm. There are fibrous bands at the wrist that are formed from deep fascia. They hold the tendons close to the bone. The flexor retinaculum covers the palmar surface of the carpal bones. Carpal tunnel is that tight space between the carpal bones and the flexor retinaculum through which flexor tendons pass. And it's from, you often hear about carpal tunnel syndrome, with people having hands in the same position for a lengthy period of time and not having enough support, let alone the fact that someone's spending too much time on a computer, which invariably happens these days. Extensor retinaculum is superficial to the dorsal surface of carpal bones. Extensor tendons of the wrist and digits pass under it. So with carpal tunnel syndrome. Space between the carpal bones and the flexor retinaculum. The flexor tendons are extending through the tunnel, and the median nerve extends through the tunnel. The syndrome is caused by compression of the nerve, and it's characterized by pain of pins and needles and paresthesia. And simply performing normal weight training type exercises with normal gripping and elbow flexion, elbow extension type motions over time can play a role with relieving a lot of the carpal tunnel issues, let alone mobilizing that wrist and performing different actions there of the forearm and the arm as a whole can relieve a lot of those tensions, let alone the fact that we have to reduce the activity that's causing the problem in the first place as much as can be done, and relieving positioning ergonomically while we're sitting at the desk as well. As far as the anterior compartment, superficial layer, the medial epicondyle is the proximal attachment for a superficial layer here of our forearm muscles. Our flexor carpi radialis, it's a prominent muscle in the lateral forearm. It flexes the wrist and abducts the hand. And when we're talking about abduction in the hand, we're talking more about going toward basically proximal deviation, basically radial deviation, as opposed to lateral or ulnar deviation, Palmaris longus is a neuromuscle on anterior forearm and weakly assists in wrist flexion. Flexor carpi ulnaris flexes the wrist and referred to as adduction of the hand, moving toward the midline, which again is more of that radial deviation. So we have the pronator teres here, flexor carpi radialis there, palmaris longus, and the flexor carpi ulnaris. That's the left hand covering the medial epicondyle. And realize, of course, the muscles of the hand are pretty much all originating more in the forearm and across the wrist. They don't originate in the hand. Intermediate later, the medial epicondyle is a proximal attachment. Flexor digitorum superficialis is the only muscle of this layer. 4 tendons attached distally to the medial phalanges of the fingers 2 through 5. Flexes the wrist, and that the middle phalanges and the proximal interphalangeal joints of fingers 2 through 5. And this is stuff you'll have to know more toward anatomy for your lab, more so than in the class. We won't be getting a lot of muscle questions on the deep muscles of the hand, the wrist, the fingers. There's a lot going on there. The flexor pollicis longus for the deep layer attaches the distal phalanx of the thumb. It flexes the MP and IP joints of the thumb. The weak flexor, it's a weak flexor or synergistic flexor of the wrist. Flexor digitorum profundus, it lies deep to the flexor digitorum superficialis. Its 4 tendons attached distally to the distal phalanges to fingers 2 through 5. Flexes the wrist, the MP joints, the PIP joints, and the distal interphalangeal or the dip joints of fingers 2 through 5. And we can see a little look here. So we have our palmaris longus, flexor carpi ulnaris, flexor carpi radialis, pronator teres here. Here's our common flexor tendon right there for the medial epicondyle. The brachioradialis coming across here in the radius. The flexor retinaculum. There's the palmar epidurosus. And from more of a cadaver perspective here, here's a flexor retinaculum, the palmar epidurosus, flexor carpi radialis, palmaris longus, flexor carpi radialis. Here's our pronator teres, common flexor tendon, the medial epicondyle, and of course brachioradialis. I'm not going to go over the deep views, go over the same muscles there, but it's something you'll need to be reviewing for lab. Superficial layer, the lateral epicondyle is the proximal attachment. It includes the extensor carpi radialis longus, which extends your wrist and abducts the hand, or ulnarly deviates the hand, essentially going out that way. The extensor carpi radialis brevis extends the wrist and also abducts that hand, or ulnar deviation. Extensor digitorum inserts the distal phalanges of fingers 2 through 5. Extends your wrist, the MP joints, the PIP joints, and the DIP joints of fingers 2 through 5. The extensor digit minimi attaches the distal phalanx of finger 5, your pinky, and extends the little finger. Just going that little finger, right? And then the extensor carpi ulnaris is the distal attachment on the 5th metacarpal bone. Extends your wrist and radially deviates that hand. Now for the deep layer, the extensor pollicis brevis helps extend the MP joint of the thumb. Extensor pollicis longus extends the MP and IP joints of the thumb. Extensor indicis extends your MP, PIP, your DIP joints of your index finger. Now take one quick look here at these guys. Here we have our extensor carpi radialis longus. Okay, going all the way through there. I'm going to come all the way in there. And our extensor digitorum, you can see here, that kind of span out here. Then we have extensor digiti minimi coming through here. We have our extensor carpi ulnaris, there. And the extensor retinaculum across, extensor digitorum tendons, all these guys. Adductor pollicis longus, extensor pollicis brevis. And it'll be the same, of course, for a cadaver, be able to locate those same locations. It's important for you to be able to do. And I won't go over it again there, but something again you have to review a little bit more. And for our muscles of the hand, within our group, it forms a fleshy mass at the base of the thumb. The flexor pollicis brevis flexes your thumb. The abductor pollicis brevis abducts the thumb, or radially deviates, going across. Abduction typically is away, remember, from midline, and adduction is toward. Opponens pollicis assists in the opposition of the thumb. Hypothenar group is a fleshy mass at the base of your little finger. The flexor digiti minimi brevis flexes your little finger. The abductor digiti minimi abducts your little finger. The opponens digiti minimi assists in the opposition of the little finger. Mid-palmar group occupies that space between the thenar and the hypothenar groups. The lumbricals are worm-shaped. They flex the MP joints and extend the PIP and DIP joints in fingers 2 through 5. Dorsal interossei are between the metacarpals. They flex your MP joints and extend your PIP and DIP joints in fingers 2 through 5. Abduct your fingers 2 through 5. Our palmar interossei, they're between your metacarpals. They adduct the fingers, flex the MP joints, and extend the PIP and DIP joints of fingers 2 through 5. And adductor pollicis adducts your thumb. And I'm going over it, and again, I remind you, it's too much for you to know right now. This is kind of you getting used to it. The hand, the wrist, the forearm. You might have a couple questions on your exam with this. This is just too much to be trying to obtain or to learn right now. But if you're going to have any future focus point whereby you're involved in physical therapy or nursing or medical field, you might be doing anything with the hand. Well, you need to know this stuff in a very specific form here. Here's our flexor digitorum profundus tendon and our flexor digitorum superficialis tendon, which is cut here. Our lumbricals here, 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 and there. We have our first dorsal interosseous, which is actually underneath here, and the flexor pollicis longus tendon. Adductor pollicis, our flexor pollicis brevis. Again, you notice how they all are contiguous with things originating more in the forearm. Abductor pollicis brevis. Our palmaris longus tendon is cut here, and our flexor retinaculum here. Again, I'm not going to go over every part of the hand there, just reviewing from different angles there. So what did you learn? You should be able to list the posterior thoracic muscles that move the pectoral girdle and describe their common actions. Which muscles extend the arm at the glenohumeral joint? Identify the rotator cuff muscles and describe their actions. What are the muscles of the anterior compartment of the arm and what common actions they perform? What muscles pronate the forearm and which supinate the forearm? What are the common actions of muscles in the anterior compartment of the forearm? What muscles in the posterior compartment move the thumb? Which group of intrinsic hand muscles is primarily responsible for moving the thumb? And then that'll bring us to our final section, which is the pelvic girdle and lower limb, and we'll talk about that for our final video section for chapter 11 shortly.